Next group of candidates, 5, 6, 7, 8. Are you ready? Who is ready from this group?
Candidate 8, I'm ready, sir.
Okay. 8 is ready. Others?
Sir, I'm 6. I'm available as well.
Okay. So 8 and 6 and okay. 5 and 7 not here. No problem. We will start. Okay. Candidate 9 also. Are you there?
Yes, sir, I'm here.
So we have 3 candidates now ready. Okay. Let's start. Okay. The first one of you can ask for control. Okay, start.
I'm presented with. I'm unable to scroll. Okay, I'm presented with sagittal T1 weighted images of cervical dorsal spine. I can appreciate that there is. I'm trying to scroll.
Take your time. Take it.
Yes, I'm scrolling on. Yes, there is a lesion in the spinal canal opposite upper dorsal levels, which is in the anterior epidural space. It shows T1 iso-intense signals to as compared to the cord and causes significant compression upon the spinal cord. I cannot appreciate any internal area of hyperintensity to suggest hemorrhage or hypointense area to suggest cystic change. I cannot definitely appreciate any other abnormal signal areas. However, there is slight waviness of the posterior contour of the spinal cord, which I will confirm on the other sequences as well. Further, I am trying to look at any major abnormality in the anterior available soft tissues.
So you mentioned
I cannot see.
about the location. It's epidural or extradural, right?
Yes.
Are you sure
Causing
about this
compression
point?
on the cord. Yes, this is extramedullary, not intramedullary.
Okay.
And it's extra.
Intradural or extradural?
It appears to be extradural.
Why?
But I will confirm on the T2 weighted and post contrast images
I'll give you
as well.
T2. Okay.
Okay, on T2 weighted images, I can appreciate that the lesion is lobulated and showing hypointense signals as compared to the CSF.
Okay.
I can see there is significant compression upon the cord, and the lesion appears to be intradural. The
Why?
lesion appears intradural, as I can appreciate the thin line of dura that is running just anterior and inferior to the lesion.
Okay. Okay.
You
I
can see my
understand.
cursor.
Okay.
And I will
Okay. Can you give me
confirm.
a differential diagnosis
Yes, I
based
will.
based
I
on
want
this
to see
two
the
images?
post-contrast images as well. However, on based on these findings, my top differentials would be meningioma and neurogenic tumor. However, I also like to see the extension of the lesion into the neural foramina.
Okay. I'll give you just a minute. I'll give you the contrast now. Yes, please. Mouse.
Okay, on post-contrast images, I can appreciate that there is intense, fairly homogeneous post-contrast enhancement of the lesion with formation of dural tail. So my first differential again would be meningioma. I would try to look at the extension into foramen, which I cannot appreciate on these digital images. However, I will confirm it on the axial images as well. So the other possible differentials could be after the meningioma and Nevian tumor, the third differential could be a metastatic lesion, or if there is no history of any brain tumor.
After meningioma, metastasis directly?
No, meningioma, neogenic tumor, and
yes.
then drop metastasis or
Okay.
any known
Okay.
with non-primary, then metastasis of the spinal canal.
Good, yes. Very good. Next,
I will communicate the findings urgently to the neurosurgeon to as this lesion is causing compression upon the cord. So I would like to urgently manage the patient, and will also further image the patient brain, or if available already, I will review the brain MRI to see any lesion in the brain as well. And I would also look at the any other findings associated with the neurofibromatosis. And
okay, that's good. Yeah.
we'll ask for genetic screening of the patient as well.
Very good. Very good. Okay, the next candidate, please.
Yes, sir. I'm with you.
Ask for control.
Requested.
Accepted. Okay.
Yeah, I'm presented with the sagittal section of cervical spine in T1 weighted sequences. I'm just scrolling through the images before I comment. Okay. I can see there is a T1 hypointense, slightly lobulated lesion located in the intradural extramedullary location opposite C2 and C3 vertebral body levels. It is also extending into the foramen magnum, and in further sections I can see the dural foramen. Sorry.
Into foramen magnum only?
Yeah, it is extending into the, it is extending till the level of cervicomedullary junction.
Okay.
And also it is causing compression of the spinal cord.
Better to assist in axial images, okay, or
Yeah.
or T2.
I wanted to check it in T2 and axial sections as well, and this lesion is also involving the neural foramina.
Good. I'll give you now the contrast. Just leave the mouse. Proceed.
Okay. I am presented with axial sections of cervical spine, post-contrast sequence. Okay, I can see there is homogeneously enhancing, intensely enhancing lobulated lesion involving the left neural foramina. And also it is extending into the extradural compartment. This lesion is causing compression of the spinal cord, and it is pushing the spinal cord posterolaterally. Okay, so depending on this appearance, my first differential would be a nerve sheath tumor like a schwannoma. And the second differential would be a meningioma, but I do not see any dural tailing appearance on sagittal sections as well. Since this is associated with neurofibromatosis, I would like to screen the patient's screening MRI of the brain to look for any associated tumors like bilateral vestibular schwannomas or associated meningiomas. I would like to inform these findings to the referring neurologist urgently in view of spinal cord compression. And also I would like to ask the history of the patient and do the genetic counseling if necessary.
Okay, very, very good answer. But Did you see the last cuts?
Okay.
Yes
Oh,
or
no.
no?
No, I did not see the last cuts.
Okay. Does it add to this case?
Okay, I'm trying to look at the posterior fossa now. Mm.
This is a post-contrast study, so you are looking for any enhancing lesions that may lead to syndromic case.
Yes, I think there is one.
Yes,
There
yes,
is an enhancing lesion in
schwannoma
the
associated
right angle.
is in F2. So you have to look for
Yeah, full sequence I
acoustic,
didn't see.
yes,
Yes.
acoustic schwannoma.
Yeah,
Like
there is an
this.
acoustic schwannoma in the right CP angle. So yeah, this patient must be associated with neurofibromatosis type 2, and
Very
I
good,
would like
Yabas.
to do the genetic counseling and inform this case
Very
immediately.
good. So
Yeah.
please, my friends, remember again, this exam is a little bit tricky. Film edge, the last cut. 99% of us will get this. It's very easy, but this is a trick. Very small enhancing lesion centered on the internal auditory canal. It's acoustic schwannoma. Together with the cervical schwannoma, diagnosis of a syndrome is made in F2. So I will revise the two cases now. Please leave the mouse. Okay. So the most common two main differential diagnoses in the second compartment, the first compartment intramedullary, the second compartment dural extramedullary. Meningioma and schwannoma both will show a homogeneous enhancement, but meningioma most likely ISO in T1, ISO in T2. Okay, I can't scroll. Okay. ISO in T1, ISO in T2, enlargement of CSF spaces, suggesting its interdural location. Enhancement here, the thin dural tail is very helpful to make the diagnosis of meningioma rather than schwannoma. Schwannoma has a very characteristic appearance of neural foraminal extension. Like in this case, it extends, it's easily assessed in sagittal. It's extend and expanding the neural foramen of upper cervical vertebrae. Okay, about enhancement, sagittal is good, but axial is better because you will mention the point that you will assess the lower part of the brain, the visualized part of the brain. It may carry another lesion like acoustic schwannoma or meningioma, anything that may lead to diagnosis of a syndrome. Okay, very good. Yeah, bosses. Bone marrow is okay. Yes. Okay, the next candidate, please. Stay with me, candidate 1, 2. Stay with me. The third candidate in this group, it's a spot image. Spot image. Just what's the lesion that may take a high T1 in a high signal in T1 possibilities.
I have been presented with a sagittal section of T1 weighted sequences of an MRI cervical spine where I can see there is an elliptical shaped lesion in the posterior thecal space, which is hyperintense on T1 weighted sequences and causing compression of the spinal column along the dorsal vertebra, likely representative of an area of subdural bleed, as I can see the posterior dural line on the superior and inferior aspect of this lesion. I would like to confirm my findings on the axial sections, and I would like to also review the gradient echo sequence of this patient. I would like to review the clinical data of this patient if there is any history of anticoagulation in this patient or trauma. However, I cannot see any vertebral compression fractures in this patient. I would like to see for the history of any coagulopathy. I would urgently pick up my phone and inform the neurosurgical department about this bleed and cord compression for
What if I
decompression in this
told you?
patient.
What if I told you the patient has insidious chronic symptoms, no acute symptoms? Any differential diagnosis other than hematoma?
chronic symptoms, then it could be fat-containing lesion.
Yes.
It could be a dermoid.
What is the next
Then I would
sequence you
review
want to see?
sorry?
What's the next sequence you want to see?
I would like to see the fat-saturated sequences.
Okay, yes.
So the lesion has completely suppressed on the fat-saturated sequences. So the other possibility is the lipoma or dermoid in this patient. And I would like to review the MRI brain of this patient.
Why?
For any other lesion.
Okay. Another case, you can scroll. This is the last case in this group.
So I'm trying to scroll, but the image is stuck. Can you scroll for me?
Okay.
Okay, I've been presented with T1 weighted sagittal cervical spine images. I can see that there is a well-defined broad-based area in the posterior thecal space, which is making a broader contact with the posterior neural arch, and it appears to lift the dura anteriorly, the hypointense line of the dura on the superior aspect. The lesion is extending into the spinal canal, causing compression of the spinal canal. I would like to see this on the confirm the findings on the axial T2 weighted sequences if I can. Okay, I have been provided with a sagittal T2 weighted sequences where I can see that there is a mixed signal intensity lesion in the posterior thecal space with the peripheral hyperintense signals and central low signals. Can you please scroll the images?
Okay.
And this lesion is actually displacing the dura anteriorly. It is causing compression of the cord. So I'll be really concerned about epidural hematoma in this patient, which is causing compression of the spinal column. And I would inform the surgical team about my findings, and I would correlate with the history of any trauma. However, I cannot see any vertebral compression fractures in the study. I would like to correlate with history of previous any anticoagulation or any procoagulative disorder in this patient.
Yes,
so
very good.
I would inform the neurosurgical department to release the mass effect on the cord because it is causing compression. However, I'm unable to see any intramedullary signal abnormality. I would like to go back. Okay, there is mild compression and minimal hyperintense signals within the cord representing cord edema. So it's an emergency to decompress this lesion.
Very good, Yavuz. Very good, Yavuz. Just we will add this to the family intradural or extradural lesions that may arise and compress the cord. We mentioned here meningioma and schwannoma. Okay, here is lipoma or dermoid. If the lesion is homogeneous, lipoma. If it is not, then we will choose dermoid. And don't forget hematoma, especially with history. Hematoma may take high in T1, okay, or very low hemosiderin in T2. Okay, boss, very good. Now another group of questions in CT brain. Okay. The first one in this group, the first candidate in this group, you can ask for control.
Yes, sir.
Okay. The last is extradural, yes. Extradural, maybe blood, maybe abscess. I accepted, just a minute. I accepted. You can scroll. Okay, good. Headache.
I'm presented with non-contrast enhanced CT brain of a patient who presented to me with headache. I'm still scrolling to the top. I can just appreciate a slightly hypertense sagittal sinus, which is likely
accepted
due to
accept. This is one of the tricky cases. This group is called normal appearing CT brain or a hidden diagnosis.
I can appreciate that there is some sulcal effacement and there is some hypodensity in the medulla and brainstem as well.
Yes, here. Diagnosis is here. In the last cut. In the last cut, diagnosis is here. You reached the diagnosis or
There
no?
is sprouting of the foramen magnum as well, which is likely due to herniation of the tonsils. I would
Yeah.
like to confirm on the sagittal images. Okay. So I'm provided with sagittal images of the same patient. I'm trying to scroll, and I can appreciate that there is so it's quite zoomed out. Can I
No problem.
zoom
No.
in?
Just no,
Okay.
no. Just leave it. Leave it. Yes. Here is
Okay. I can appreciate that there is significant herniation of the cervical tonsil into the foramen of magnum, which is causing compression upon the cervical junction. I cannot see any associated abnormalities in the brain, corpus callosum, midline structures, or sulci or posterior fossa. So the appearances are likely in favor of carry 1 malformation leading to the tonsillar herniation.
Thank you.
I will
just to comment on presence
the
or
patient.
absence of headache of hydrocephalus. So remember, my friends, just leave the mouse. Remember, in a normal appearing CT brain, look down, look up, look for hidden areas. I will mention after some cases most of hidden areas that you may face in the exam. So remember, crowding of foramen magnum or tonsillar herniation, easily missed if you didn't see the last cut from below. Okay, very good, yeah, boss. The second candidate in this group.
Yes, sir.
Okay, you can start scrolling. Headache.
Okay. Okay, I'll just request for control.
Yes, yes. Or I'll tell you no history. No history given by the examiner. Okay.
Okay, okay.
Any problem scrolling?
Okay. I'm just trying to scroll. Okay.
You want my help? Are you there?
The
Internet is not good. Internet is not good. السلام عليكم.
عليكم السلام.
اوكي. ايه كونكتد. اوكي. عادي يا جماعه النت المصري. اوكي. اوكي. Are you with me, boss?
Yeah, I'm with you, sir. I'm with you.
Okay. I'm sorry for this disconnection. You can start again, please.
Yeah, I'm requesting for remote control.
Yes.
Requested, sir.
Accepted. Okay.
Okay. Okay. So I am presented with axial sections of CT brain. I'm just trying to scroll through the images before I comment.
Okay.
This is a non-contrast CT brain.
Keep talking. In the exam,
there is an extra axial mass, broad-based mass lesion, which is located in the left high frontal lobe, with a broad-based dural attachment.
Good.
It is seen to compress the brain parenchyma with mild sulcal effacement. There is mild age-related cerebral atrophic changes in the form of prominent ventricular system and sulcal spaces. Otherwise, I do not see any other lesions in the brain parenchyma. However, I would like to see this in the bone window to see if there is any hypertrophy of the associated bone, frontal bone, and there are no evidence of calcifications within this lesion.
Good.
In my routine practice, I would like to see the post-contrast study for this patient to see the enhancement. Based on my interpretations, I think this is an extra-axial broad-based dural mass likely to represent a meningioma. But I would like to assess this patient in post-contrast study as well.
Yes, it is recording. It is recording, inshallah. I think the patient, this patient, do you want to ask anything from history, any differential diagnosis for meningioma? A dural-based lesion, meningioma.
Extraaxial dural-based lesion, hemangiopericytoma is another differential, but it would cause more bone destruction.
Okay.
It is more aggressive lesion.
Okay.
Another could be it is not a cystic. Epidermoid cyst or edemoid cyst can present like this, but they are cystic lesions, and which it is similar to the CSF
You
signal
mentioned
intensity.
it's a solitary lesion, correct?
Sorry, sir.
You mentioned it's a solitary lesion.
Yeah.
Yes.
It's okay.
No
Yeah, there
problem.
is there is another smaller lesion in the right side as well.
Yeah.
This also shows similar signal characteristics and broad-based dural attachment. So there are multiple meningiomas in this patient.
Yes.
There are multiple meningiomas in this patient, and this patient could most likely be associated with neurofibromatosis type 2.
Okay, neurofibromatosis type 2 can be diagnosed earlier, but I'll tell you the history. This patient is 75 years old, female, with palpable breast lump. What is the diagnosis?
Palpable breast lump. Okay. So then this could be a metastasis from the breast carcinoma.
Yes. Okay, don't help. Don't help my friends. Okay, don't write the answers first. Okay, what other differential? So the main differential now is meningioma in younger
And
ages. In younger ages.
yeah, in younger patient. Yes.
So you
So
have
this
to.
patient.
Yes, continue.
And this patient had a history of breast carcinoma, so I think this could be the metastasis from the breast carcinoma.
Okay, other differential for a dural lesion.
I could think of maybe a nerve sheath tumor, but this is unlikely to present.
You mentioned hemangiopericytoma, but unlikely in the setting of this appearance. Okay.
Yeah.
So it's meningioma, it's dural metastasis, it's dural lymphoma. Lymphoma, my friends, lymphoma and metastasis can be in the form of lesion or dural thickening, meningitis. Okay. Very good, yeah, boss. I remember this is a dural metastasis from prostate, by the way, not from breast. Okay. So primary tumors that send dural metastasis may be breast, prostate, lung. Okay. Very good, yeah, boss. So again, my friends, in a normal appearing CT brain, don't forget to go down the most inferior cut, looking for any tonsillar herniation. Go up for the most high cut. You may find a meningioma that may help in diagnosis of neurofibromatosis 2, a dural metastasis, meningitis, thickening of the dural. Okay, or also,
Sir, this can be sarcoidosis. Dural thickening.
Downward, sarcoid and the TB, dural thickening, but at the basal meninges, not high. In high and if associated with mass, think of lymphoma or metastasis. Also, the highest cuts, look here for any subarachnoid hemorrhage, for example, or any diffuse axonal injury. Very good, yeah, boss. The next candidates in this group, I think the last one.
Yes, sir.
Okay. Ask for control, yeah, boss. This patient found unconscious. Okay, proceed.
So I have been presented with axial sections of the CT brain, non-contrast study in a patient who has presented with history of unconsciousness. I'm trying to scroll through the images.
Don't repeat the complaint.
Sorry?
Don't repeat the complaint.
Okay, sir.
By the way, I'm not bad examiner, but this is happening. Okay.
No, sir, it's fine.
Some examiners speak with you in a tough way. Most of us try to repeat the presentation to take some few seconds while looking, as you do now. You are looking during my talk, okay? So the examiner may push you to the edge, may speak with you in a hard way. So please stay calm. Stay calm. Don't lose your nerve, okay? Okay, boss. Any finding here?
I'm scrolling through the images. I'll do a quick scroll and then I'll talk about my findings.
Okay, scroll till the end, till the last cut, then come. So in the real exam, please stay calm, okay?
So there was no obvious finding on the first scroll.
Okay, good.
So now I would look at my review areas.
As the patient is found unconscious, maybe.
So the superior sagittal sinus appears relatively hyperdense.
Just normal, okay. Any other finding?
Bifrontal region, extraventricular CSF spaces are relatively prominent in bifrontal region. But I do not see any hyperdense area in the subdural bifrontal regions.
Good.
There is a minimal area of edema.
Till now, where?
Here on this left medial part of the temporal lobe with central hyperdense focus.
Okay.
Which is leading, it's likely presenting a partial volume from the lateral ventricle.
Okay, stay here. Just a minute. I will guide you. No problem. I will guide you. Leave the mouse, please.
Okay.
Okay. What about this section? Comment on vascular structures. This patient is suspected, in old age, suspected to have a stroke.
So there is a relative hyperdensity of the right middle cerebral artery, which might represent.
Compare it with the left. Relatively symmetrical, right?
Okay.
What about the vessel posterior to the middle cerebral? Yeah, yes. Okay, let me guide you again. Yes.
Yeah, this vessel, yes, this left posterior cerebral.
Yes, it's asymmetric. No similar vessel on the right side. So this may be the pathology, right?
Okay, it's asymmetrically dense, but it's relatively straight for the course of the posterior cerebral artery. That's why I just.
So what is it? You ignored it?
Yeah, I had looked at it. I thought it's like quite straight for the posterior cerebral vessel. That's why. But there is a hyperdense vessel in the posterior half of the circle of the villus, which is asymmetrically dense as compared to the right side, likely representative of the left posterior cerebral artery thrombosis. So in this patient with suspected stroke, I would like to proceed further with an MRI brain, including the diffusion weighted sequences with stroke protocol to look for any diffusion flare mismatch. So if the patient is within the time window of less than 6 hours, it could be referred to the regional stroke center for embolization, and so that the spline brain parenchyma of posterior cerebral artery can be salvaged?
Yes, very good, yeah, boss. Very good. So remember, my friends, again, just click the mouse. Okay, typical finding in a typical location. Many of us are used to see this dense sign in the middle cerebral, not in the posterior cerebral. In middle cerebral, yes, middle cerebral artery dense sign, but unusual to see it in the posterior cerebral artery. Here it's a dense sign also, or dense vessel sign in the posterior cerebral artery. Yes, for thrombectomy, yes, okay, or intra-arterial catheter injection, I think, not embolization, yes. MRI is better, of course. MRI is better. Very good, yeah, boss. Very good. This is an example of hidden cases. I will continue now with another group of friends. Are you there? The next group, if any one of you is ready, just tell me.
I'm candidate 11 and I'm ready.
Okay.
Yes, and 12, I'm also available.
Okay, 11 and 12, 10 and 13, are you ready? Okay. Let's start with these two candidates now and start with spine. Ask for control, yeah, boss. Start.
Yeah, I'm provided with sagittal T2 image of the lumbar spine. I'll first scroll through the images. So there is dural ectasia with posterior scalloping of the lower lumbar and upper sacral vertebrae. I'm checking if there is any intra dural masses. Well, the conus medullaris seems to have an adjacent hypointense signal. I would like to, if contrast enhanced images are available, I would like to confirm if there is any conus medullaris lesion enhancing lesion.
So any
I'd also like
any provisional diagnosis from this sequence?
so posterior scalloping of vertebral bodies with suspected conus medullaris lesion. I would be suspecting myxopapillary ependymoma, but other that's negative. Then I would be thinking about neurofibromatosis type 1 associated dural ectasia or a dural ectasia in Marfan syndrome. I would like to check patients.
T1, same patient.
Okay, this is T1 sagittal of the same patient. I'll scroll through the images. There is some delay in the scroll.
No problem. The main idea, you mentioned two main differential diagnoses: dural ectasia of neurofibromatosis and mass lesion. Can you suggest one possibility over the other from this sequence?
Well, it shows CSF signal in the dural sac, so I'm favoring neurofibromatosis or dural ectasia due to neurofibromatosis or Marfan syndrome over.
I'll give you the contrast.
Okay.
Back again in my words, please.
Okay, so there is a heterogeneously enhancing lesion is extending from the from the conus medullaris down until S2 level, filling the lumbar canal and causing the posterior scalloping. Appearances are typical for myxopapillary ependymoma. I would like to confirm to convey my findings to the treating physician for neurosurgical consult and discuss the case in the spinal tumors MDT. Also, maybe imaging of the rest of the neural axis, though myxopapillary is rarely associated with the drop mets, but
Okay, good, yeah, boss. The next candidate, I will answer the two cases together. Okay.
Yes.
Next candidate, please ask for control.
Yes, I have requested.
I accepted. Okay. Start, yeah, boss.
Now I'm scrolling.
Yes, you are.
I am provided with MRI lumbar spine T2 sagittal images in which I can see that there is dural ectasia, which is extending posterior to the lumbar vertebrae and lower down in the sacral region. This is resulting in the scalloping of the posterior margins of the lower lumbar vertebrae and the sacral bodies. I can appreciate that there is low-lying conus and their conus medullaris appears to be extending up to the L4 vertebral body.
Good.
I can also appreciate that there is some heterogeneity within the bright signal, which I'm concerning for any fat density present within this signal, which I would like to confirm on the T2 or T1 weighted images. If it is hyperintense, then this could represent lipoma.
I'll
I'm
give you
looking at
T1.
the,
I'll give you T1.
Oh.
Just delete the mouse, please.
okay, sorry.
No problem. Okay.
Okay, now I'm provided with the sagittal T1 weighted images where I can see the same findings with the dural ectasia and the low-lying cord and conus medullaris. I'm scrolling through the images and looking for any fat intensity here. There is slight lag in the scrolling of the images, but I'm looking. I'm
No.
looking at the posterior elements. I cannot appreciate any definite defect there. I cannot see any T1 hyperintensity to suggest lipoma. And so to conclude with these findings, they are in with the low-lying cord and conus medullaris, resulting in the teeth ring, and no definite spinal lipoma is appreciated. I will immediately call the neurosurgical team and inform my findings regarding this
Okay,
low-lying.
a question to you, boss. What are other differential diagnoses of posterior vertebral scalloping?
So it could be any intraspinal lesion. Other
Like,
differential intraspinal lesion like mucopapillary ependymoma, which we have just seen, or it could be any other neurofibroma, which is causing the scalloping. It could be seen in acromegaly, and it could
Good.
be seen in achondroplasia. And these are the differentials,
Very good.
mainly for the posterior scalloping of the vertebral bodies.
Okay, another question outside this case. Anterior vertebral scalloping. What are
Yes.
the causes?
For anterior vertebral, it could be any long-standing aneurysm of the aorta, which is
Good.
resulting in the anterior scalloping, and it could be
Retroperitoneal lesions, like
retroperitoneal lesions. Yes, the long-standing one could be no.
lymphoma or
Okay,
tuberculosis.
lymph nodes.
Okay,
Okay,
tuberculosis. Nice, yeah, was nice. So these two cases represent a dilatation of the cecal sac, the lower part of cecal sac, with a smooth posterior vertebral scalloping. It means a long-standing process, most likely a benign process. The trick here was in the first case. It looks very high in T2, like CSF, but if you look carefully here is the signal of CSF. It's a little bit different, and it is not continuous with the CSF. So this is the most likely a soft tissue lesion, okay? But it's okay to mention these two possibilities. In T1, it is not a CSF signal again. It's slightly higher than the low signal intensity CSF. And of course, because it's soft tissue, it's heterogeneously enhancing. This is a case of maxillopapillary ependymoma. But here it's CSF signal in T1, in T2, and continuous with the CSF itself. Okay. This is WhatsApp. Just leave the mouse. Leave the mouse. Okay.
Oh, sorry.
No problem. Okay. 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 So it carry a differential diagnosis of posterior vertebral scalloping, maybe just a dural ectasia of neurofibromatosis or intraspinal lesion like maxillopapillary ependymoma, phylum terminal, or conus lesions, astrocytoma, and schwannoma. Even schwannoma, if large schwannoma, it can cause posterior vertebral scalloping as well. Congenital lesions like achondroplasia and acromegaly can cause it. Anterior vertebral scalloping, congenital lesion like Down syndrome, acquired lesions, lymphoma, TB, abscess, and of course aortic aneurysm. Okay, now to MR brain or CT brain. Okay, MR. I'll give you now this case, yeah, boss. You can start. The first candidate, okay? Are you ready?
Yes.
Ask for
I'll
control.
request control, yes.
Take it.
Thank you. So I'm provided with axial brain MRI T1 with image without IV contrast. I'll first scroll through the image. So nothing catched my eye in the first scroll, so I'll go again, checking my review areas.
Yes. Hidden areas. The most inferior one looking for what? The most superior one looking for what? The Sellar region. Okay?
Yes.
Sellar is one of the hidden areas. Do you see anything?
Yes, there is a lesion centered in the sellar area with extension into the suprasellar stern. The lesion shows relatively homogeneous in T1 weighted image, which is slightly high signal. It's
ISO signal, not high.
I mean slightly high to the gray matter. Okay,
Yes.
Okay.
Just leave the mouse, please. I will unmute one of our friends. Okay, continue, yeah, boss. I'm sorry.
The lesion is extending. It's going the reverse way. Is extending into the sphenoid sinus and inferiorly. I'm suspecting extension into the cavernous sinus, but I would like to evaluate it on the coronal view, better on the contrast enhanced section.
I will give you the contrast. Just okay.
Okay, this is axial T1 with IV contrast of the brain. The lesion is homogeneously enhancing. So differential diagnosis of a Sellar lesion with homogeneous enhancement would include meningioma and macroadenoma, but I would favor meningioma for the homogeneous enhancement. Such a large macroadenoma would usually be heterogeneous, more heterogeneous, but I would like to check the coronal and sagittal reformats.
Which one is more invasive, macroadenoma or meningioma?
Macroadenoma is more invasive than meningioma.
This lesion is already invading inferior to the Sellar. It's already invading the sphenoid sinus. Okay, so I think this is number one. But I agree with you. We will use other planes like coronal and sagittal, looking for what?
I'd look for it is based on the
Yes.
sphenoid. I mean the ethmoid.
Any
It would
dural
be
base, any
meningioma.
dural base, or any dural enhancing dural tail. Okay, this is an example of
Of macroadenoma with
yes,
snowman sign
pituitary
appearance.
macroadenoma. Excellent, Yavuz. Excellent, Yavuz. Okay, the next candidate. Yes, snowman appearance, classic here. Okay,
Yes.
the candidate asked for. I will give you just a minute. Okay.
I'm provided with MRI of brain, T1 weighted coronal sequence. I'm scrolling.
I'm sorry, T1.
Sorry, pair images.
It's okay. It's T2, but not classic. Okay.
Okay,
Okay,
let me
continue.
revise it.
Okay.
I'm provided with the coronal images, and I can see that there is. I'm scrolling. They are not moving. No, they are moving. I can see that there is an isosignal lesion seen in the suprasellar region, which appears to be extending anteriorly up to the ethmoid bone. It is also causing the encasement of the bilateral ICS in the cavernous sinuses along their superior aspect. However, their flow voids are preserved superiorly. I'm looking at the optic chiasm, which I cannot appreciate very clearly, likely compressed by the mass effect of this lesion. There is, I'm looking in the Sellar region for the pituitary gland, and in these images, I cannot very clearly differentiate the Sellar area, which I will confirm on the sagittal images, if I could see the pituitary gland separate from this lesion.
I'll give you,
Otherwise,
sagittal post-contrast to complete the case.
okay. Okay, so I'm provided with the sagittal images, which show that the pituitary gland is seen separate from this lesion. It is extending anteriorly along the planum sphenoidale, and it is showing the enhancement. I'm scrolling the images to look for any dural tail. Yes, I can see that there is some enhancement along the dura anteriorly. It is extending posteriorly along the basilar artery, but it does not appear to be causing much mass effect on it. And the optic chiasm is almost completely compressed by this lesion. So on these findings, my first diagnosis is of meningioma. Possibility of this being macroadenoma appears less likely, as I can see the pituitary gland very well placed and well circumscribed within the
Excellent,
fossa,
excellent.
pituitary fossa.
It has
I will convey my
dural tail
findings.
and dural base as well. In case of sellar or parasellar lesion, the main idea is to localize the lesion. Where is the epicenter? Usually, we will face these cases in axial. So if the first look you missed it, no problem. Just review the hidden areas. One of the hidden areas is a sellar region. Another one, remember, the pineal region as well. So we have here suprasellar and sellar. Where is the main bulk? It's present in the region of the sellar, centered on the sellar. So it's mainly sellar lesion with supra and infrasellar extension. This is a macroadenoma. But in case of this minute. Okay. Yes, this lesion is predominantly suprasellar. Suprasellar enhancing lesion. What is the differential diagnosis? Suprasellar enhancing lesion.
So it could be meningioma.
Yes.
It could be germinoma.
Excellent.
Mets could come in the differential.
Yes, excellent. And of course, suprasellar extension of macroadenoma. And this is by instance.
Yes.
Okay. What if I told you, because we are about to finish, I'll give you one or more differential. Any other candidate want to share? Any new candidate?
Okay, I can share.
Okay, okay. Try to answer this case in the same group.
How can I scroll? Sorry.
Ask for control.
Mm. Sorry, I can't do it.
I will scroll for you. Okay.
Okay, it will be better. Thank you.
No problem.
Okay, so I'm provided with MRI of the brain FLAIR sequence. I can see at the Sellar region there is a well-defined lobulated
Good.
hyper-intense lesion with as well as a suprasellar allocation predominantly has a high signal with bright rim around it. I
Good.
just want to have a look at the ventricular region, please,
Ventricle.
because I could see, yeah, there is a high signal here within the thalamus, right thalamus, and within the third ventricle as well. I believe this could be an extension of the lesion. So can I have a look at the sagittal
I'll give
sequence,
you
please?
sagittal post
Yes.
contact. Give me two
Okay.
differential diagnoses that may cause this pattern.
Germinoma could be coming
Germinoma,
on.
yes.
Yes.
Suprasellar and biennial.
Biennial.
Good.
Yeah.
Other differential?
Other differential diagnosis can be I don't remember about.
No problem. Anyone can write now. Other differential lesion of suprasellar and posterior lesion. Other
Trilateral retinoblastoma, could it be?
Good.
Trilateral.
Okay. What else? Syndromic. Glioma. Yes, glioma in the optic and the optic pathway. Okay. So if you find, please, my friends, if you find a suprasellar lesion, go back. Comment on the pineal region, comment on the optic pathway, occipital lobe, because it may be syndromic. Okay. One possibility of the suprasellar lesions, remember, it's glioma. It's neurofibromatosis type 1. Oh, I see here suprasellar lesion, but what is this?
Yeah, it's optic nerve glioma.
Yes, it's bilateral. Oh,
Yes.
it's neurofibromatosis too.
No,
You may also find lesions along the posterior pathway as well. Yes, there is arachnoid cyst. Yes, arachnoid cyst in posterior fossa. Okay. So again, suprasellar lesions with enhancement may be extension from macroadenoma. The epicenter of the lesion usually in the cell itself. Maybe craniopharyngioma. Oh, craniopharyngioma maybe totally enhancing. Yes or no?
Papillary type.
Excellent. Yes, this case totally enhancing suprasellar lesion in an adult. One of the possibilities is papillary type. BAAB, papillary in adult, adamantinomatous in pediatric. Okay, so if the lesion suprasellar is predominantly cystic in pediatric age group with some calcification, this is adamantinomatous. It's a craniopharyngioma. So again, suprasellar enhancing lesions, extension from macroadenoma or papillary type craniopharyngioma, meningioma if dural base with enhancing tail, germinoma, look for pineal region, glioma, look for optic pathway or optic nerve itself, and don't forget metastasis. Don't forget metastasis, okay? I think this case has a cancer breast as well. Okay, my friends, I think enough for today. I am sorry, we're about 2 hours now. I tried to cover some differential diagnosis in the spine and in the brain. We can't cover the whole system in 2 hours, okay? Inshallah, I will try to make another, thank you. I try to make another session, maybe the next Friday, inshallah. We will try to cover the chest, also in a differential diagnosis, okay? Thank you, ya bosses. Thank you.
Okay,
Best
thank
of
you.
luck.
Thank you so much.
Best of luck. Assalamu alaikum
Thank
wa
you.
rahmatullahi wa barakatuh.
Thank you.
Welcome.